All right. Actually, before we get started, Senator Bertzel, could you lead us in the Pledge of Allegiance?
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome. Thank you all for being here today. I think I've probably met most of you out there, but for those that don't know me, my name is David Rochefort. I'm new to the Senate this year, and I'm excited to be chairing this committee, and I think we've got a good day to get started here. So with that, we're going to open the hearing on SB 18, permitting the Commissioner of Health and Human Services to authorize additional beds for a pediatric intermediate care facility under certain circumstances. I see the prime sponsor is already here, Senator Rosenwald.
Thank you very much, Mr. Chair. For the record, I'm Cindy Rosenwald, State Senator from District 13. And I'm pleased to introduce Senate Bill 18, which will enable the DHHS Commissioner to evaluate whether New Hampshire's only pediatric intermediate care facility, which is Cedar Crest in Keene, needs more beds and how many more they might need. And what I think is important about this bill is that it does it without breaking apart the long-term care bed moratorium, which has been in place since 1995. So for 30 years, we've had a moratorium on long-term care facility bed expansion. And this has been an effective cost savings mechanism since facility care is more expensive than community-based care. The moratorium is also important because people want to stay in their communities and not be institutionalized. New Hampshire was also the first state to close our institution for children with developmental disabilities. And we've long prided ourselves on the fact that we partner with families to provide the array of services that allow many children to stay at home, live with their families, even if they have complex needs. As context, over the last 2 years, we have authorized first 1 and then 2 additional beds at Cedar Crest temporarily, allowing them to bring a couple of New Hampshire children back to the state to be closer to their families. Last year, Cedar Crest told me they thought there might be 4 or 5 additional New Hampshire children who would qualify for their care, but are currently being served out of state. So this bill will allow the commissioner to assess the need for serving New Hampshire's children with complex developmental and medical needs, and give the fiscal committee the authority to approve any recommendation for additional beds. This is prudent because any expansion of beds could lead to increased costs for the Medicaid program. I think it's a common sense bill, and I hope the committee will look on it favorably. Happy to answer questions.
Senator Long.
Thank you, Mr. Chairman, and thank you, Senator, for your testimony. I'm more concerned about the criteria for establishing this. Is it that there are no community-based services available for somebody that we may increase the beds to have them there? I'm just wondering what we're looking at, what's required to look at to increase the beds.
Well, Cedar Crest does a couple of things. One, it takes children with complex developmental and medical needs, like maybe they need a respirator for longer stays, but they also do respite care for families. There is a workforce problem in the community. We know that there's a lack of personal care service providers through the area agencies. But some of these children with more complex medical needs probably are less easily served in the community because they need actual nursing visits. And there are other people who could speak more about that. But I think it would be a real mistake to just start taking apart the long-term care moratorium. I mean, that has been in place for 30 years, and it's done a couple of things. One is it's helped us rebalance our long-term care system so that we put more emphasis on community-based care. It's on us, really, as funders, to make sure that the workforce is there because it's what people want, it's what families want, and it's less expensive than institutionalizing someone.
Right.
So I think the commissioner would have to look at how many kids there are out there, especially from New Hampshire, who would qualify for Cedar Crest's level of care under Medicaid, would have to look at how often Cedar Crest beds are full, which is not always, and make a recommendation. And then the fiscal committee would be a vetting for that recommendation because we're going to have to pay for it.
Very good, thank you.
Yes, Senator Prentice?
Thank you so much, Chair, and good morning, Senator Rosenwald. So simply, this gives the commissioner the authority to continuously monitor the census if there is a need for one of these complex, developmentally disabled or medically complex patients that needs a space in New Hampshire, to be able to make an ask for that with approval from the fiscal committee, and it basically cuts out a step and gives them that flexibility. So it seems to be more responsive and timely.
Yes, I think so. It's not a requirement for the commissioner to undertake this analysis, but it allows the commissioner to look at this and say, Cedar Crest could use X number of new beds, and we have no idea what that number is.
Thank you.
No further questions from
Thank
here?
you
Thank
very
you very
much.
much.
Thank you. Should I leave the microphone on?
Sure, yes, we've got somebody coming. Yes.
Okay.
So the next speaker we have on the list is Jay Haston from Cedar Crest.
Good morning, and thank you so much for having me. I'm Dr. Jay Haston. I'm the president and CEO of the Cedar Crest Center for Children with Disabilities. As many of you are aware, we provide exceptional complex care and education to our state's most medically and developmentally complex children. And that's an important distinction where we're a medical service first. We have a population specialty that is children with developmental differences. Our job each day fundamentally is to manage those incredibly challenging medical, developmental, and therapeutic needs so that our state's most fragile kids can be kids, so that they can learn, that they can play, and that they can grow. As the senator mentioned, we are licensed as an intermediate care facility, and we are the only intermediate care facility in the state. As of today, we serve from infancy through age 22. To give you an idea of that medical complexity, 40% of the children that we serve are on ventilators for all or part of the day. 100% rely on G or GJ tubes for enteral feeds, so they get their nutrition through a feeding tube. If you are familiar with other nursing homes in the state, you know it's very rare to find a single ventilator in a skilled nursing facility. We have 10 today. We also provide special education in an approved private school on our premises, as well as respite care to give families and caregivers a much needed break. Important to clarify, many may already be aware, we're a post-acute setting, so a big part of what we do is between hospital and home. So many of the younger children in particular who come to Cedar Crest come after a stay in the hospital, oftentimes born with complications, perhaps needing mechanical ventilation, and they come to Cedar Crest for some period of time while the family is getting trained, while the child is getting medically stable. Transitions home, participating in the idea that the goal is to get as many children home as possible is core to what we do. It's why we operate a respite service at a huge loss, because there are over 24 families last year who tell us that they were able to maintain the placement home, maintain the placement in the community by having the respite service at Cedar Crest. And it's respite where additional capacity is particularly helpful because when we are full on long-term admits, it constrains our capacity to provide a respite service. A couple other bits of context. Last year, we had 7 long-term admissions, 4 discharges, and 62 different respite stays. We received over 100 inquiries, approximately 60 of which may be appropriate for one or more of our services. Our average age of admission is just under 7, and the average length of stay over now a long period of time is approximately 3 years. So that includes children who are with us for a very short period of time, a few months, up through children who may not have a family situation to go to at present, who are with us for longer periods of time. The demand for our level of specialized medical support has increased by 30% over the past 3 years. We receive more inquiries per month than we can currently support. Although it is important to note, as the senator alluded to, there is significant seasonal variation in our demand. Because so many of the children that we serve have respiratory needs, significant respiratory needs, during respiratory illness season, we see a downturn in admissions. So right now I have 25 occupied beds, where multiple times this year we were fully occupied at the 28 that was authorized last year. Our workforce at Cedar Crest continues to be strong. I think in part because of our really compelling mission, we have the medical care, the therapies, the education to support some additional capacity. What we don't have is the type of permission to do so that we're talking about here today. Families and children need our services, given we are the only environment that fits in this part of the care continuum. Hospital partners and care teams want to discharge to us, particularly when a child is done with their acute stay at the hospital. They're ready for a post-acute environment, but not necessarily ready to be home. It's also prudent for taxpayers because our daily rate is between 2 and 6 times less than the daily rate that would be required in the hospital. And I feel very comfortable saying for almost all of the children that we are serving today, if they were not with us, they would be in the hospital. They're unable to be supported elsewhere at this time. We are very grateful that our capacity was temporarily expanded again last year. We did utilize that capacity multiple times throughout the year. We maintain an active list of respite and long stay inquiries. As the senator noted, there are multiple New Hampshire residents currently being served in hospitals out of state. That is sometimes a family preference. Families, especially out this way, may prefer that their care go out of Boston for the specialized services that are out there, whereas folks who are closer to Keene, where we are, may have their care go out of Dartmouth. But it is the case that there are New Hampshire residents that may track for an admission at Cedar Crest who are not currently in New Hampshire. We are thankful, particularly for the senator identifying a more durable pathway to consider and respond to this need without requiring legislative consideration or amendment in the way that we have this year and over the past 2 years. We serve a really unique population whose needs are well met in our setting, and as the only setting for them, I'm really appreciative for you all hearing this bill and giving it consideration.
Thank you. Any questions from the committee? Seeing none, you're free to go.
Thank you.
That's it for folks who have signed up ahead of time to speak. Is there anyone else that would like to speak on this bill? Senator Rosenwald, is there anything more you'd like to say? I'll give you that opportunity. If not, we'll. And I do that because I've been the prime sponsor and
I
have.
hope you'll just pass it.
I said, I want to give you the last word, so.
Well, thank you.
As a prime.
I
so.
think it's a good bill. We've worked hard with Cedar Crest, with them and their lobbyists over the last couple of years, and the New Hampshire Healthcare Association. And I think it's a common sense solution that, as Mr. Haston said, avoids going through the legislative process. So it's a little more nimble and could just go from the commissioner to fiscal.
Great, thank you.
Thank you.
So I'm going to close the hearing on Senate Bill 18. And actually, I would be entertain a motion to open executive session on Senate Bill 18. I've got a motion and a second. So we're in executive session, Senate Bill 18.
Move on to pass.
I have a motion from Senator Avart ought to pass, a second from Senator Prentice. Just for my own understanding, do we roll call that or do we?
You asked for discussion first.
Okay.
Is there any?
Any further discussion? Yes. Seeing none, we'll call the vote. So all those in favor, say aye.
Aye.
Any opposition? No?
Consent?
Consent.
Second.
We'll go on consent.
All those in favor?
All those in favor?
Say
aye.
Say aye. Aye.
Aye. Thank you. Thank you. I'll get this. This is
Motion to move out of exec.
we got a motion.
Second.
All right.
Oh, I'll take it
All
out
right.
since I'm on it.
Okay.
I'm co-sponsor.
All right. Senator Birdsall will take it out. So we are.
Waiting for the next vote.
All right. So we're good.
And I'll just take back all the sign sheets.
Okay, yep, very good, thank you. All right. Next one up is Senate Bill 37. Relative to residential care and health facility licensing. So we'll open the hearing on Senate Bill 37. I know Senator Pearl is not going to be here, so Kate, if
You
you
don't think I'm
could
Senator Pearl?
let you go.
Good morning. My name is Kate Littman. I'm the Majority Policy Director for the Senate. I'm introducing SB 37 today for Senator Pearl. So SB 37 was made at the request of DHHS. And I'm going to highlight a few key points for the bill. It's pretty simple, but I think it seems more complicated than it is because it amends a lot of RSAs. And I made sure each of you had a copy of the bill so you can follow along with me. So if you look at section 1, it's revising RSA 150.15C. So in the statute currently, as you can see, quality assurance programs are voluntary for licensed residential care facilities. And section 1 makes quality assurance programs mandatory at these facilities instead of voluntary. If you look at section 2, it amends RSA 150.161 to expand the types of residential care and health facilities that may be investigated by DHHS for violations under this statute. and to require the results of those investigations to be posted in a conspicuous place in the facility. It also requires the results be posted, or the results that are posted to include facilities and the services investigated in the results, which is not the case currently. Section 3 amends RSA 151.6A to C to require these facilities to post the results of life safety inspections, known as notices to correct. And as you can see, in the current law, it explicitly does not require these life safety inspections to be posted as notices, so that's the change that's being made in that one. Section 4 amends RSA 151.16B by removing the words administrative fines because the section or the statute and law right before that already covers administrative fines. Then sections 5 and 6 amend the patient's Bill of Rights by changing the term hospital to the term facility in 2 places. And I'll come back to that section because we're going to need a committee amendment for one tiny change that was caught that I think some of you have been made aware of. But it just changes, make these 2 changes to the patient's Bill of Rights to apply to more types of facilities than just hospitals. And if you want the definition of facility, I have that, but I thought that was a little bit too nitty-gritty. Section 7 amends RSA 151.50 by removing the word continuing from the initial education requirements and then replacing the term ongoing training with continuing education in the annual training requirement. So like I mentioned before, popping back to section 6, we're just gonna need a tiny change that was caught by Carolyn Virtue, where you're changing the word hospital to facility, but later in that sentence, it still says written hospital policy. So we just need to change hospital to facility just to bring that in line with the change that's being made in the previous line. And I can, in theory, answer some questions on what I said, but the HHS is here to answer more in-depth questions I think I can't answer.
Great, thank you. Senator Abar?
Yeah, so on that change of wordage, I didn't write it down fast enough what you just said.
So on page 2, line 9,
Yeah,
it says written hospital policy. So the committee amendment would just be changing hospital to facility
facility.
so that it comes in line with the rest of that sentence where we're striking hospital and replacing it with facility,
Yep.
just so that it says written facility policy.
Thank you. Just one word and I didn't capture that. Thank you.
Any further questions from the committee? All right, thank you very much. So the next speaker I have here is Attorney Danielle Warbies and Kelly Keefe from DHHS. Good morning.
Good morning, Mr. Chair and committee members. My name is Kelly Keefe. I am the Licensing Unit Chief for the Bureau of Licensing and Certification at the Department of Health and Human Services. And with me, I have Danielle Warboys.
And my name is Danielle Warboys. I'm General Counsel and Legislative Liaison for the Bureau of Licensing and Certification at DHHS.
I would like to thank Senator Pearl for sponsoring this bill and Kate Littman for introducing Senate Bill 37. As it is a department-requested legislation, we are in support of it. The intent of this bill is to ensure patient safety and well-being by requiring transparency of healthcare facilities to improve patient care and outcomes and reduce adverse events. Currently, quality assurance programs are optional for licensed residential care facilities in law. The proposed legislation would amend RSA 151.5C to mandate quality assurance committees. Nothing else would change. The details and meeting minutes remain confidential and privileged. Currently, only clinical survey results are posted for the public in law. The proposed legislation would amend RSA 151.6 to require investigation results and amend 151.6A to require life safety survey results be posted to the public. The proposed legislation would remove the word administrative fine from 151.16B, the section on civil penalties, as there is already a section on administrative fines. The bill revises the patient's Bill of Rights by making the references consistent in Section 21 by using the word facilities rather than hospital, making it applicable to all licensed healthcare facilities. The bill seeks to clarify the language in Section 50 by removing the word continuing from initial education and replacing the term ongoing training with continuing education in the annual dementia training requirements. Thank you for allowing us to speak, and we're happy to answer any questions.
Thank you. Any questions from the committee? I just have a quick question. So when changing the quality assurance program to voluntary to shall, I imagine that accreditation organizations that oversee some of the places all are already requiring that?
Yes, this actually is specific to residential care facilities that are not accredited or certified. But we have a section in 151 applicable to hospitals. So yes, to that point, and also home health, which are usually certified, they
Okay.
require it as well.
All right, and then my other question is, so posting results from an investigation, I'm assuming, and correct me if I'm wrong, I'm assuming that the results would be fully adjudicated results, not
Correct. They would be founded
preliminary
on-
or allegation, okay.
Correct.
All right. All right, very good, thank you. Seeing no more questions, you're free to go. Thank you. Thank you for coming in. Next on the list is Carolyn Virtue.
Good morning, Senator Rochford, members of the committee. I appear before you this morning because I had a concern with the bill when it first came out that was related, believe it or not, to my misunderstanding. Sorry, I'm going to the lined copy. On page 1, Roman numeral 1, number 1, it talks about health facility licensing, and my agency is licensed by health facilities, and it says confidentiality. And it seemed to just drop there to me. My agency has had some issues with the department refusing to honor statutory confidentiality that exists in we're licensed under home care, the home care licensure statute. So I was concerned about that not being included in here, but I've been assured that this section relates only to residential care facilities, not all facilities. I appreciate Senator Pearl and the department taking the time to walk through this bill with me and alleviate my concerns, and I appreciate them fixing my minor editorial comment.
Great, thank you. Are there any
And
questions?
I'm happy to take any questions, or
Seeing none, thank you for coming in.
thank you for having me.
All right. It's Jake Berry, New Futures.
Good morning, Mr. Chair, honorable members of the committee. My name is Jake Berry. I'm the Vice President of Policy at New Futures. As many of you know, New Futures is a nonpartisan, nonprofit health policy and advocacy organization. We've been working for many years to increase access to quality and affordable health care here in the state. I don't want to repeat too much of what's been said here this morning, but I do want to stress New Future's strong support for this bill. Throughout much of our history, especially in recent years since the release of New Hampshire Public Radio's 13th Step podcast, we've worked closely with many of you to strengthen oversight and patient protections across our healthcare system, especially in the behavioral health space. We have another bill moving forward in the House that hopefully we'll have an opportunity to discuss with you later this session. But for today, in our work around patient protections, we found that few things are as important to protect the health and safety of individuals and families as enhancing public awareness. Certainly, we support the work the department does to license our healthcare providers and and hold them to high standards. But the fact remains that the outcome of investigations and license suspensions can be difficult for many patients to access, and oftentimes remains hidden from view at a time when they need this information most. By requiring facilities to post the outcome of investigations physically at facilities, this bill would make this information more available to patients and families who are often at their most vulnerable, individuals in substance use treatment, elders at assisted living facility, and others. I don't know that this will prevent all violations and misconduct, but it will help patients to be aware of it and help them to make informed decisions to support their own health and safety. This will enhance public confidence in our healthcare system, and again, really go far to hold our healthcare providers to higher standards to enhance patient protection and safety. So with that in mind, we encourage you to support this bill, and I'm happy to take questions.
Great, thank you. Any questions for Mr. Berry? Seeing none, thank you very much.
Thank you.
Next on the list is Susan Buxton.
Good morning, Mr. Chair and members of the committee. Thank you for allowing me to speak this morning. I am Susan Buxton. I'm the State Long-Term Care Ombudsman. I'm also a member of the New Hampshire State Commission on Aging. The Office of the Long-Term Care Ombudsman is a required program of states receiving federal Older Americans Act funds. Our office works to resolve problems related to health, safety, welfare, and rights of individuals who live in long-term care facilities, assisted living, nursing homes, and other residential care communities. We do this through education, investigation, mediation, and advocacy. Ombudsman programs promote policies and consumer protections that support the well-being of people living in long-term care settings. The New Hampshire State Commission on Aging exists to advise the governor and the legislature on issues related to aging in response to our state's changing demographics to an older population. The commission has studied long-term care issues and supports increasing transparency of care environments. One of the things that our office does frequently is take calls regarding how to select a long-term care facility from both individuals and their families. One of the things that we recommend people do is check for regulatory compliance. There are two types of inspections and two areas of inspection. So there is an annual inspection and there are complaint inspections, and they are related to health issues such as medication administration and other clinical areas, and life safety, which is compliance with, say, fire drills and other life safety building codes. The current New Hampshire law, RSA 151, does not make public inspections, any inspections regarding life safety, and it does not make public complaint investigations. Under federal law, the Medicare, Medicaid program, all inspections are made public for nursing homes. So it's just assisted living, residential, and supported residential care where there's a limited amount of information available. This is a public safety concern. Vulnerable adults and or their caregivers should have access to this information. We also work to investigate and resolve complaints that are filed by people living in long-term care or their families. So our role is advocacy and mediation and between individuals and facilities. The Department of Health and Human Services is involved in the same process, but their job is to ensure regulatory compliance. There have been complaint investigations that have resulted in DHHS identifying regulatory noncompliance that resulted in regulatory oversight. However, complainants are barred from receiving the results of those findings. And that lack of transparency to the complainant is problematic for bringing closure to the complaint and creates an environment of distrust that is hard to overcome. This bill corrects these issues, and I encourage you to pass it as written. I'm happy to take any questions.
Any questions from the committee? Seeing none, thank you very much.
Thank you.
All right, the last one on my list here is Ben Bradley.
Good morning, Mr. Chairman and members of the committee. My name is Ben Bradley. I'm the Vice President of State Government Relations for the New Hampshire Hospital Association. We represent all the acute care hospitals in New Hampshire and all specialty hospitals. We understand that SB 37 relative to residential care and health facility licensing is a request of the department and makes changes to RSA 151, a chapter which regulates our members as licensed hospitals and other licensed healthcare facilities, with some exceptions relative to statutes specific to residential care facilities or where hospitals are recognized with deemed status by CMS. Given that hospitals comply with requirements from the Center for Medicare and Medicaid Services, conditions of participation, which include transparency, expectations for noncompliance, and reports of compliant investigations, as well as an existing mandate to maintain a quality assurance program, I've expressed interest in working with the department on this bill to ensure the state does not enact redundancies that create unnecessary regulatory burden for our hospitals. In my conversations with the department, they are very willing to work with us and get us to support this important legislation. CMS, as I mentioned, already conducts complaint investigations and publishes on their quality certification and oversight reports website the results of any complaint investigation with a substantial deficiency in the last 6 months. And I've provided, or I will provide, the committee with an example of one of these reports issued by CMS because of a complaint investigation in Connecticut. I appreciate the department's willingness to work with us and would be happy to answer questions for the committee.
Great, thank you. Any questions? No questions.
Thank you.
Thank you very much. Is there anyone else who'd like to speak on Senate Bill 37? So with that, I'm going to close the hearing. Have a motion. I would take a motion to go into executive session.
Mr. Chair, we
Yes.
have 9:30 is scheduled.
Oh, we're behind schedule. Okay, all right. I'll hold that. Let's hold that thought then. What do you say? All right. Seventeen. Open the hearing on Senate Bill 17 relative to insurance cost sharing calculations. And Senator Innes. Would you like to introduce your bill? Sorry to interrupt.
Good morning.
Good morning.
Good thing I had that second cup of coffee. All right. Good morning. I'm Dan Innes from Bradford, New Hampshire, representing District 7. And Mr. Chair, Vice Chair, and committee members, it's a pleasure to be before you this morning to introduce to you Senate Bill 17. And Senate Bill 17 was effectively passed last year by the Senate 24 to 0. And it's my hope that the Senate will look favorably on this particular bill again. Let me give you a little bit of an overview, and then I will try to take any questions you may have. There may be others who can answer those questions just as well, if not better than I. Senate Bill 17 is an effort to improve affordability and reduce patient out-of-pocket expenses, which will have obviously a real impact on the citizens of the state of New Hampshire. The need for copay assistance for prescription medicine is really critical for citizens who have high deductible health insurance plan that may require them to spend thousands of dollars before their insurance actually kicks in. Copay assistance, whether it's from a GoFundMe campaign, a church, a manufacturer, it's real money. And copay assistance isn't a discount or a coupon, nor is it a way to steer patients away from or toward branded medications. And you'll probably hear testimony to that effect in just a minute, and I'll share one brief statistic on that fact shortly. The patient is prescribed their treatment by their physician or healthcare professional. Copay accumulator and maximizer programs allow private insurance companies and pharmacy benefit managers to reap significant profits, while patients living with challenging conditions like MS, cancer, psoriatic arthritis are forced to abandon or delay their treatments due to high out-of-pocket costs. For many, this high cost sharing requirement makes it impossible for them to afford medications that are needed to treat a wide range of chronic and sometimes rare diseases without the copay assistance offered by a number of pharmaceutical manufacturers and other charitable organizations. Most of these programs exist for drugs without generic alternatives. Regrettably, health insurers have worked to block patient access for much of this needed assistance. Over the past several years, an increasing number of health plans and PBMs have begun implementing cost-shifting tactics like accumulators and maximizers. Instituted by insurers and PBMs, these accumulator adjustment programs bar third-party provided copay from counting toward a patient's deductible or out-of-pocket maximum. So if you imagine for just a second, you maybe have to do cancer treatments for $10,000 a month. Your insurance company pays $8,000. The drug manufacturer says, we'll help you with that $2,000. And the insurance company says, thank you very much, but doesn't apply that to your deductible. You're still responsible for your full deductible. So this exposes patients to large and unexpected costs. It interrupts treatment regimens. I've seen it happen with my sister in another state where she suspended her treatment for 2 months because of this very situation. She has rheumatoid arthritis. It interrupts or undermines patient protection, and that's the antithesis of what we're about here in New Hampshire. Copay maximizers are similar to copay accumulator programs, set a patient's cost-sharing amount to be the maximum value of copay assistance spread throughout the year. How many people would be affected by this in New Hampshire? Estimates are about 310,000 patients in the state of New Hampshire would be affected by this program, should we be able to get it done. Finally, just a couple more quick comments. You may hear again that this bill will result in less use of cheaper alternatives, namely generics, but 99.6% of copay assistance is used for branded drugs that do not have a generic alternative. So when you hear shortly the opposite, this is a fact, and I've got the numbers, and I'm happy to back that up. A recent American Cancer Society survey of cancer patients and their caregivers pointed out that 83% of respondents felt that the manufacturer assistance program enabled them to get the medication they otherwise couldn't afford. Senate Bill 17 would put an end to this insurer double dipping and ensure that patients get the full benefits of copay assistance and have it count toward their deductible. Thank you for listening to my testimony, and if there are any general questions, I'll do my best to answer them.
Senator Eber.
Thank you. Just one question. How will this affect insurance rates?
You'll likely hear that insurance rates will go up substantially as a result. Will there be some impact? There very well could be, but that's what insurance is about, sharing risk and helping one another get through things. The increases should not be significant, but the benefits to individuals are.
Thank you.
Any other questions for Senator Innes? I guess you're off the hook.
All right.
If you want to hang around, you can, I'll give you the last word, but there's a number of other speakers.
I will say, I'm not sure the insurance department is testifying today because
They're not on the list.
They're at another event, I understand, in Manchester. That was the whispering in my ear over there. So, you know, I'm sure we'll have an opportunity to hear from them at some point should it be necessary.
Sure we will. Yes,
Okay.
thank you.
Thank you. I appreciate it.
So let's, the next one we're gonna go with, let's see, Paula Rogers is on the next one here. I saw Paula here.
Mr. Chairman, I would waive speaking at this time if somebody who's simply a citizen of New Hampshire is here to testify.
I do have somebody here. Thank you very much. We'll call up Susanna von Ettinger. Apologize if I got your name.
And thank you very
Okay. Good morning. My name is Susanna von Ettingen. I live in Warner, New Hampshire. I'm a New Hampshire state lead for the New England Bleeding Disorders Advocacy Coalition, a collaborative advocacy effort for patients with hemophilia and other bleeding disorders and their caregivers. I'm also the mother of a 27-year-old son with severe hemophilia A, a bleeding disorder in which blood does not clot after trauma to the body, be it a severe cut or an accident resulting in internal bleeding in joints or other body parts. In 2024, I testified in support of Senate Bill 354, and today I'm here once again to testify in support of Senate Bill 17 to prohibit health insurance policies from incorporating copay accumulator adjustment programs. I'm just going to say caps in my discussion is on. As you're aware, these caps disallow third-party assistance with a patient's copay because that amount of assistance is not applied to a patient's deductible or annual out-of-pocket maximum, as Senator Innes had mentioned. I believe this is detrimental to patients by increasing their medical expenses and drug costs, and quite possibly might lead to decisions to not take costly, life-saving medications in order to save money. Decisions that may ultimately result in increased medical costs from more severe illness. In 2024, when my son turned 26, he was taken off of my insurance policy, and we looked to the state insurance marketplace to find a policy that would cover his expensive medications. We discovered that the broker with whom we worked had never encountered copay accumulator adjustment programs. Not surprising, because the prohibition for applying assistance to a patient's deductible is hidden within the policy and not clearly defined. Typically, these programs are only 1 to 2 sentences, buried deep within an explanation of benefits. Wording can change in these policies to mislead patients and consumers of insurance. After hours on the phone with staff from 2 insurers whose policies seemed to best fit my son's needs, we were able to ascertain that yes, one company did have this program. To our point-blank question if accumulator adjuster program existed, the agent would not admit the program existed, but in an email stated that only amounts that the member is paying would contribute. No discounts or co-payments from the drug company will apply towards the deductible. It's only the out-of-pocket expenses from the member. This clearly indicates that that policy has a cap. The other insurers simply didn't respond to our inquiries. We never heard from them. Secondly, as a subcontractor, my son's monthly salary is barely sufficient to cover all of his medical and living expenses at this time. If he has to decide between rent, electricity, or a monthly copay of $250 or more for specialty medications, it's highly likely that he will put off his biweekly prophylactic doses in order to make the medication last, or wait longer to take his clotting agent after an incident, which he needs to take immediately. One slip on the ice and a twisted ankle or knee will put him out of work for days and cost much more than his biweekly dose or post-injury clotting factor. He'd be lucky if that's all that would happen. We are not unique in being affected by the caps implemented by insurers. As Senator Innes pointed out, there are many other chronic diseases that also require costly and life-saving medications and are equally impacted by caps. This bill, as Senator Innes pointed out, only covers non-generic medications, thereby limiting the patient pool affected by Senate Bill 17. My son is one of those patients as he has no generic option and most likely can only use one particular brand of clotting factor. Otherwise, he may develop an inhibitor, which then would require far more doses of this very expensive clotting factor. So we are pretty much married to this factor for the rest of his life. We do not get coupons for his medications. We don't get credit cards. We don't have copay assistance. It's a direct payment between the third party and the specialty pharmacy for those with hemophilia. I'm unaware of how it's dealt with elsewhere. Our son's medication, by the way, is not available in a general pharmacy. You have to go through a specialty pharmacy. And if he were to go to a hospital, it's most likely they don't have clotting factors either, unless they have a hemophilia treatment center. That's how rare this medication is. So I did a little deep diving. The methodology section of SB 17 states that the insurance department asserts that premiums will increase with the prohibition of caps. Peer-reviewed literature, which I did, and a 2023 analysis of the annual rate of insurance premium increase indicates that insurance rates have not been affected in the 19 states, the District of Columbia, and Puerto Rico when this study was done in 2023. We have yet to see evidence that premiums have risen beyond the anticipated regular annual increases due to copayments by third parties and the concurrent loss of monies patients pay to meet their annual cost-sharing programs, so what the insurance company wouldn't get. I question how the insurance department concluded that insurance premiums would rise because I can find no supporting documentation in the published literature. From the methodology section of SB 17, I'm going to read it if you don't mind. The department states that insurers employ precise actuarial methods to estimate premium costs based on the previous year's claims experience. These estimates are used to design plans to achieve an optimal balance of premium and cost-sharing attributes to meet a myriad of market characteristics. If extraneous revenue sources are applied to assisting enrollees in meeting their cost-sharing responsibilities and/or these costs are met with non-real dollars, this would disrupt the economics of cost estimation among the affected health insurers and consequently drive premiums upward. So basically, I'm understanding that insurers are increasing the expenses of chronically ill patients reliant on non-generic specialty medications so that the economics of cost estimation is not disrupted. It would be helpful to understand the data used to make this assertion, how it is collected, and who analyzes it. The actual revenue loss, market characteristics, I'm not exactly sure what that means, that are used to support this assertion. I look forward to a continuing dialogue with the New Hampshire Insurance Department in order to understand the position the department has taken regarding this bill. My family and I thank you very much for listening to our story and for your support of Senate Bill 17.
Thank you very much. Are you open to questions? If we have any?
Oh,
Do you have any questions? I just have a curiosity question.
Yes.
It's not necessarily relevant to the bill. You said you have to get your son's medication at a specialty pharmacy.
That's correct.
Is the specialty pharmacy owned by the insurance company or the PBM?
No, the specialty pharmacy is associated with our hemophilia treatment center.
Okay.
However, there are, I believe, specialty pharmacies that are owned by like Caremark or
Yeah.
CVS, so by pharmaceutical stores and
Yeah, I
Other
asked that
agents.
because the Federal Trade Commission came out with an interesting statement
Yes.
yesterday, and figured you were here, I'd ask you. Thank you very much.
yes, thank you for your time and listening.
Paula, do you want to come back? All right.
Thank you, Mr. Chairman. And members of the Health and Human Services Committee, greetings. For the record, my name is Paula Rogers, and I am here this morning on behalf of America's Health Insurance Plans, more popularly known as AHIP. And
Oh, I'm sorry. I'm having a hard time. Can you pull the microphone a little closer? Oh, yeah. perhaps shut off the other one.
Is that the one I should use?
No, I think that with both of them on there, yeah, that will help.
Okay.
All right.
Should I start over, sort of?
Thank you.
Paula Rogers,
Yes.
AHIP. Okay.
Again, you can tell I don't hear very well, so thank you.
So good morning. And I'm new to this issue, and I'm new in government relations capacity with AHIP, having been sort of out of the scene here for several years. And so when I signed on with AHIP, and quite thankfully, Senate Bill 17 popped up as one of the earliest bills in the LSR column that had actually a printed form, I started looking at it. And I also went back on the docket for the bill that was introduced last year and ultimately died in a committee of conference over on the House side. So what you have before you, basically, is last year's bill, as it was presented to the committee, 354, except for one change. There is a change in each section of the bill. There are 3 sections in the bill. One first section I'm going to focus on because sections 2 and 3 are replications of the first section. But that first section has one change at line, it's line 9 in Roman 2 with the sentence that begins this requirement. So it's it's an alternative when there is a generic medication, is an exception to the mandate of the plan that any copay payment coming in on point of sale at the purchase of a pharmaceutical be applied to that enrollee or member's calculation of where they are on cost sharing. So if you look at the very first Roman 1 of the section, you'll see cost sharing requirements are referenced as coinsurance, copayment, deductible, or out-of-pocket max. And that's a valid characterization of what they are. So this bill would basically mandate that the coupon that a manufacturer provides to a member at point of sale would be registered for its value in the deductible of that plan member or enrollee. Right now, there has been reference, and my prior speaker actually did that. She referenced programs of the plans that use maximizer or accumulator mechanisms to adjust to what is basically monies being paid on behalf of a member from another organization. And in this instance, the copay premium is the copay coupon is being paid by a manufacturer, a pharmaceutical manufacturer. So when you heard last year from patient advocates, I think it was the Cancer Society, you also heard from the leukemia folks and those people who had blood bleeding disorders, they all struggle at point of sale with expensive medications. And the issue is that you heard from patients, you heard from plans, and you heard their unique perspectives on this issue. But there was one missing ingredient to think what you heard. I looked at the Senate HHS minutes on the hearing, and I thought, well, surely there will be manufacturers in the audience. And they will come to the fore and answer questions that are probably going to arise in your minds about, well, how does this work? We have a manufacturer, we have a payer, we have an enrollee, there's tension in the system, there's an unaffordability or immediate unaffordability challenge. What is being done to accommodate that? Now, when you heard from the groups who have patient assistance programs, you heard substantial and concerning stories about people struggling with the cost of prescription drugs. Had you had a pharmaceutical company sitting here where I'm sitting, I would suggest that you would have been prompted to ask them questions about the cost of the medications. How does the cost of the medication get determined in the market? Are the controls over the cost of medications within the market? In the United States, actually, that is not the case at all. It's quite regularly within the purview of the manufacturer to test the market with the cost for a particular drug. If you were to go to other developed countries, mostly in the Western European countries, you would find that coupons are probably much less commonly used, if at all, and you would not find direct-to-consumer advertising. So you have manufacturers in this country who have basically marketing initiatives that focus on two main sources of returns on marketing. They do make, indeed, and manufacture wonderful products. There's no doubt about it. But in the marketplace, you are deluged with ads for medications. You are, if you went into your computer and simply looked for coupons around pharmaceutical products, you would be sourcing an immense array of opportunities to find support for purchases of pharmaceutical products. Mention was made by the prior speaker of the Department of Insurance's fiscal note on this bill, and I know there was one on 354 from last session. I think the department rightly looks at the fact that plans create their products. The products are reviewed in a regulatory setting. The actuarial standards are reviewed and approved by the department. And the products are constructed in a way to address the market challenges of providing an expansive coverage with some share of the cost of that coverage borne by an individual. Nobody likes, I suppose, a deductible, a copay, or any coinsurance at all, but to make the product affordable, it's a reality of our current marketplace that plans are structured in a way to allow for that cost share to be placed on the member, the purchaser. It's a reminder, of course, and I don't like the term, but it's the skin in the game, i.e., if a person is paying something before the full coverage is available with no restraints, they should think quite clearly about what medical services they are going to seek, and they should seek to find, if possible, on their formularies, which are also part of the insurance product and reviewed by the insurance department, they should carefully search their formularies before simply responding to a drug manufacturer coupon. Prior speaker also brought up the marketplace that would be covered by the bill before you, and she is quite right. She mentioned about 200,000 people in New Hampshire who would be part of the individual small group and large group fully insured market. This bill does not cover Medicare, it doesn't cover Medicaid, it doesn't cover self-insured programs, it wouldn't cover the state employee program as it exists. And so it is a narrow area of the marketplace, but quite frankly, the marketplace is always sensitive to premium pressure. And yes, the department did say there would be upward pressure on premium if the bill passed in its present form. They did not exactly quantify that. That's difficult to quantify. But we know that right now pharmaceuticals represent a significant part of the spend on healthcare provision. And the pharmaceutical formulary and the cooperation between PBMs who deal directly with the manufacturers and the plan that uses services of PBMs is a system that is in place. It has its deficiencies, it has its critics, but I think you want to be very cautious before you simply pass a bill, which in its present form, I might also add, covers more than pharmaceutical. It would cover any medical cost, I believe, that would be coupon susceptible. And I think the department pointed that out. I think you need to be cautious. Now, last session, the bill left the floor of the Senate and went over to the House. During the Senate hearing, an amendment was proposed that got no action within the Senate, Commerce, House and Human Services Committee. So the bill went simply with the amendment on generics to the floor, went to the House, went to the Commerce Committee, and then sort of oddly, the amendment that was mentioned in the House Senate hearing appeared in the House version of the bill after lots of work with the House committee. The interesting thing about that amendment was it tried, unlike what has been the example in other states, which when this mandate has been brought forward in other states, many states have simply adopted it pretty much as presented it, sort of throwing up their hands, maybe not thinking carefully about, is it a way we can serve a number of interests if we sort of confine the application of having the copay coupon go to the deductible? Is there a way we can carve that back and see if it might have a social purpose that is probably more progressive? And so the Senate, the House amendment did a number of things, and I wanted to list to you what it did. It clearly limited the scope of the copay issue to prescription drugs. It recognized independent charity assistance programs. It required that assistance from those programs be included when the member's cost share is calculated and accumulated. And when recognizing these independent charity assistance program, it was really focusing in on some sort of means testing, because the programs would be focused more on people within a certain range of financial capability. If you look at the coupon programs for assistance programs that are often funded quite generously by various disease not-for-profit entities, they service individuals whose income, I think, will go as high as 500% of the poverty level, which gets, I think, for a person would be probably upwards of $150,000. So I don't know that manufacturers ignore people that have incomes higher than that. I suspect not. But I think that the other thing that you might want to think about is a notification. If indeed you were to narrow down the number of coupons that received the benefit of being calculated into where the member is with cost share, a notification requirement that would go to the plans, because the plans don't always know that a coupon has been used at point of sale. And so you look at the amendment on the House side, it had a notification requirement. I'm trying to think, was there anything else in there? Oh, another problem that results with copay coupons is they may be initially helpful to the member at point of sale, but evaporate during the plan year. They may be short-term. That is problematic from a patient protection point of view. And so that would be another amendment that I think would be appropriate, and I think it was in the House side of the amendment. What happened, of course, is it went to a committee of conference, and division arose within that conference, understandably. And I remember Senator Bradley particularly, because I went into the YouTube tape on that because I wanted to see what led the bill to fail in the Senate and the House. And it was a step back that Senator Bradley focused on, feeling that maybe the bill wasn't as generous as the bill that came out of the Senate. We would look at it to say that it was in more ways a more careful bill in that it was focused on independent charity participation in the copay issue and on a group that probably is the most burdened with the cost challenges at point of sale. So that leads me to say that from AHIP's point of view, while we oppose the bill in its present form, we worked on the amendment on the House side, and we would want to continue working in that direction, that if there's going to be a mandate on insurers to credit manufacturer coupons to a member's cost share calculation, that it be used in a way that doesn't, that allows for the manufacturers to send their coupons and people to use them anywhere they want. It won't impede the marketing programs around coupons, but it will focus a benefit on those people in a certain situation, income-wise, and that the the charity that is providing the copay, coupon, or payment is indeed one less connected to, quite frankly, the pharmaceutical industry. The charity that would be recognized, the independent charity, is, I believe, a Health and Human Service Inspector General entity, in that directives of how that charity is to behave is held to standards that the Inspector General has control of. So that was basically why things fell apart on the House side, why Anthem continues to feel there is some merit in this bill, but it should be pared down and try to get at what we think is really an essential reduction of a span of application, but to the most needy of users and with less marketing coming from the manufacturer side.
Any questions? Senator Ebert.
Thank you, Paula. You always bring a great perspective on these pieces of legislation. If we pass this, it's not going to put any pressure, even with all those amendments, on the manufacturer to lower their cost, will it?
It's putting pressure on premium for the health carrier.
But not on the manufacturer.
The manufacturer, it's very difficult. And you know what's interesting? I looked at the record that came out of the Senate hearing. I don't have as meticulous notes for what happened over on the House side. But I went down through those people that testified and, health plans, PBMs, patient advocates, all very good testimony, I assume. The notes were excellent that came out of your committee. There were no pharmaceutical manufacturers there. But this bill is really about pharmaceutical manufacturer coupons. That's what I don't understand. And it's a marketing tool. Yes, it has community benefit. There's no doubt about it. But it is a marketing tool, and it's a productive marketing tool. In fact, physicians feel that, sometimes their members have already decided what medication they need before they've even been diagnosed with a condition. That's because of advertising. And so we can't do anything about that. That's a federal level issue. But we're, if you're a Netflix enrollee and you think you could watch a film, suddenly you've got a Wegovy ad going on and you think you know those people because you see them so frequently in that little town where everybody's marching down the street. And so that it interferes, I think, with patient care in a way. And so that sounds sort of old-fashioned, doesn't it? We should, have access to everything. So I don't want to criticize the manufacturers, but the reality is it is marketing. And I assume they're behind this bill.
It doesn't put any pressure on.
Way behind it. Now, I know the advocates are right there, and everything they say is, leads one to worry and be concerned. But the dynamics they're distressing. So if we could come up with something out of the bill that was acceptable and sort of focused on maybe a portion of the population where the need may be critical or more critical, But listening to the prior speaker, I mean, the cost of medication in tens of thousands of dollars, that's a federal problem. If you went to France, I would guess that medication is not 5,000-10,000s. So we're sort of where we are, and that's not much we can do about that. So I'm hoping some manufacturers will come up and answer some of your questions that you may have about, well, you know, what do you do about a $50,000 drug? Yes, it's a wonderful drug and you developed it and.
So,
Any questions from the committee?
so the $50,000 drug, do the PBMs have any role in causing that price to be $50,000?
There are probably PBM people here that can answer that question.
I'm going to, all right, they're
So
going to get the
I
same
mean,
question.
you know, I would assume there's some price pressure and coming from many different directions. And we all need transparency. We all need to understand it better. But the PBMs can answer that question. Obviously, PBMs get paid by health plans. And the other issue out there is, well, can they get paid in rebates or should they not get paid in rebates or what proportion? So there's all of that going on and that's all good discussion. I don't have any problem with any of that.
It's as clear as mud.
Well, and it may be clear one week and then, you know, the business shifts. It's just the competitive thing that's a perfectly natural thing in a society like ours where capitalism is the theme. And you can't entirely quash that. So the question is, how do you sort of hem it in a way that looks rational and that people don't get left behind? And if they get left behind, that the people that are lining up behind them are not in part funded by people who still have a profit motive in the whole thing.
Yeah. And actually, that wasn't my question. My question was, what's the difference between what we're talking about today and having a copay discount card or a charity organization go to the cost share, that's the bill that we have in front of us. What's the difference between that and me paying for my neighbor's $500 copay? If I wanted to do that, am I prohibited to do that?
You could do that. The plan wouldn't. Well, no, you wouldn't want to do that at point of sale. You would give your neighbor $500.
What's the difference? I mean, what's the difference?
Well, the manufacturer, the difference is that the manufacturer is a business entity, a for-profit business entity. It's paying, and you should ask the members of health plan members who will be here, you should ask them what happens when the money is collected at the point of sale. Say it's $250. Where does that go? Where does that go?
Yeah.
I mean, there were statements last time that the plan simply pocketed it. It does not, to my knowledge, do that. But I think you should ask plans directly that question.
All right.
And I'm sure they have an answer.
So everyone, get ready. Get ready to answer that question. Thank you very much. Is there any other questions? All right. Thank you very much. Let's see. Curtis Berry. Curtis, I see you're with PCMA, also with Sam Halmeyer. Do you want to come together?
Please. Yeah.
All right.
Thank you, Mr. Chair, members of the committee. My name is Curtis Barry. I'm here representing PCMA, or the Pharmaceutical Care Management Association, which is the National Trade Association for the PBM industry. And before I let Sam introduce himself, I'd like to answer, what I think was the last question, Mr. Chair, that you had. I think there's a very important distinction between cash assistance that's provided by a charity, a church group, a relative, et cetera, and a manufacturer coupon. I think those in the very first category, if you have a relative or a group in your community that wants to help you with your copay, I don't think they have a stake in what drug that assistance helps you pay for. They want to help you get your drug, whatever the prescriber, the healthcare provider prescribed. The manufacturer coupon is specific to the drug. a specific manufacturer and a specific drug. So this is related to Ms. Rogers' comment about what is accepted. So the bill does accept the case where there's a generic. It does not accept the case where there is a lower cost name brand alternative. That again is an important distinction. It also doesn't cover, which I hadn't considered if you look at the fiscal note that's noted by the insurance department. It says, quote, however, the bill does not specifically recognize branded biologics and its similar biosimilar equivalents, which are often branded as well. So there are a lot of drugs that may be lower cost, similar to the generic exception in the bill, that maybe should be considered. So I just wanted to answer that question because it was fresh in everybody's mind.
Yeah, do we have handouts?
I'm sorry. I got carried away. We have handouts.
Good morning, Chair Rochfort, Chair Avard. My name is Sam Hollmeyer with PCMA, which is the National Trade Association for America's Pharmacy Benefit Managers. Curtis and I are here today to oppose Senate Bill 17, which is an act relative to insurance costs and insurance cost sharing calculations, and we are here opposed to the bill. So we are handing out now our written testimony along with some additional handouts. So I'm going to summarize my my testimony this morning. But our main concern with this bill is that it will steer patients towards more expensive drugs and therapies under the guise of a lower copay. But what happens when that copay runs out or the copay coupon is no longer offered by that drug manufacturer? Then the patient is on that more expensive drug regimen with no patient assistance. Next, we're also concerned that this will just ultimately raise premiums for everyone in the plan, while only a few would receive that lower copay. It was mentioned previously, but I want to mention again that these copay coupons are banned in government programs such as Medicare and Medicaid, as they are considered kickbacks. I do have some specific stats I want to point out in the testimony, but I will summarize them. So we do find that copay coupon list prices are increasing faster than drugs without a copay coupon. Again, I just mentioned the ban in Medicare on these, and we find that if copay coupons were allowed in Medicare, it will result in an increase of $48 billion over 10 years. Again, that's in the Medicare program, which they are now not allowed. We do find that there's a 20-to-1 return in profits on manufacturers, and it was mentioned previously that this is a marketing tactic, and we agree with that. And then other states such as Massachusetts have produced reports showing that, yes, while it does result in lower copays for some, it will increase premiums for everybody in those plans. So finally, rather than lowering the cost of their list prices, drug manufacturers have found that instituting these copay coupons to steer patients toward these more expensive drugs will increase their profits and increase premiums for everyone in the plan. I am happy to answer any questions at this time, and thank you for allowing me to provide comments.
And if I could walk through a couple of the handouts.
Oh, yeah.
So one point I'll make also, it was brought up earlier, what the bill does not apply to. As Sam mentioned, it does not apply to Medicaid because it can't. It's banned as a kickback. But interestingly, it could if you chose to make it apply to the state employees plan. That's within your purview. And my view is, if you think this bill is good policy and the patients who are in a fully insured plan, which is a minority in the state, then why wouldn't it be good policy to extend to the employees and their families that are in the state employees plan? It seems to make sense that they should benefit from this policy too, if you think it's a good policy. I think the fact is that the cost is not negligible. I think what you would hear from the Department of Administrative Services is that there is an additional cost, which then means there's an additional cost in the fully insured market as well. So back to perhaps an indirect way of answering the chair's other question about the PBMs and the costs. Keeping in mind that coupons are applied to name brand drugs. Why are name brand drugs expensive? One of the handouts you have is a list that looks like this. It's a year old, but it's a portrayal of just a handful of the tactics that pharma manufacturers use to extend the patents on their name brand drugs. Some of the more recognizable drugs on here, Humira, 311 patents, 287 of those patents come after FDA approval. Keytruda, also recognizable from the television ads, 180 patents, 111 of them after FDA approval. And the list goes on. They make a slight tweak to the chemical formula, get a new patent, and keep that drug in the patent and in a name brand drug and keep the price high. Another handout is a Vasante study, an independent study showing what this bill, this concept would do in Medicare Part D, would raise costs. And then a chart describing the profit margins in each of the several players in the drug reimbursement distribution system. You can see that the pharma profits are quite healthy. And lastly is a handout taken from an AARP study issued a year ago, January of 2024, that shows you in the bottom chart the cost of a therapy per drug and the cost of a therapy per drug if their price was limited to inflation. There are recent studies that came out just this year as pharma raises their prices that once again, a significant number of them are far beyond the pace of inflation. So if you want to know where the increase of price drugs comes from, it starts with the manufacturer. Again, happy to answer questions, Mr. Chair.
Any questions? I have a question. So the coupons, let's talk about the coupons. You know, they come from the manufacturer, and we've discussed why that's different than me paying for my neighbor's prescription. Are PBMs collecting any fee or recoupment or rebate on the coupons that are used? So if it's a $500 coupon, does the PBM get to keep a little bit of that?
Thank you for the question, Senator. I'm not aware of that happening now. No.
Okay. All right. Check that one. So, I'm not going to comment on that because it's not a question. Nah, it doesn't serve the purpose of the committee. It's just causing trouble. I don't have any further questions. Does the committee have any? Right? Oh, yeah, Senator Long.
Thank you, Mr. Chairman. Couple questions, if I may. Do you agree that the $310,000 is roughly the amount of people that would benefit from this?
310,000 people that was cited. I think we'd all have to research that. That sounds high to me, based upon the number of lives that I'm vaguely aware are in the fully insured market versus self-insured or government or Medicaid or Medicare. That sounds awfully high. And that may just be the total number of people in the fully insured market and not necessarily the people that receive coupon assistance, if that makes sense.
Follow up, if I may.
Yeah, absolutely.
And the benefit to the enrollee, like you stated in your testimony, that the premium may go up. However, I'm looking at the benefit of the enrollee as far as the premium going up. They may pay part of that or what have you. So with respect to the premium going up, does the enrollee still benefit?
I would say yes, those few people who are receiving coupon assistance will benefit, but please keep in mind, currently coupons are not banned. The only issue at question relative to this bill is that manufacturer coupon for a specific drug applicable to the deductible? That's the patient can still use the coupon. The question is, does it apply to the deductible? And what happens is, Paula had mentioned a provision that was discussed on the House side that made the coupon, if it were applied, made it apply for the whole plan year. I guess I would put it this way, you have to ask, besides the patient, who benefits, right? So if the patient is eligible for a lower cost drug, but the coupon is offered at some point, somewhere between the prescriber and the pharmacy. And it's in the patient's financial best interest to use that more expensive drug because they have a coupon. It costs less for the patient. The drug is still more expensive. And what happens is the coupon expires or is not used, not applied once the deductible is met. Meaning, and this is where the expense comes in, meaning the plan, all the rest of us, then pick up the cost for the rest of the plan year for that more expensive drug.
Thank you.
Thank you for that question.
Something I can't get past here. And as you know, I've been on the receiving end of these as a pharmacist, and I've seen a lot of these coupons, and I understand, in my experience, they are used for newer, brand name, more expensive drugs. And but isn't it the PBM's job to determine whether or not those drugs are going to be covered or not? I mean, that's what we're told is it's up to the PBM to determine whether or not you're supposed to be saving us money. So if you've got a brand new drug by the drug manufacturer that's overpriced, it's not worth the price, and you've got a bunch of generic drugs that could be working better and it's cheaper, isn't that your job is to say, no, we're not going to pay for that. There's cheaper alternatives here. So I kind of see that what gives here? I mean, if this is really, we shouldn't be taking these drugs and we shouldn't be, paying for these things. I mean, that's your job to make sure they don't get paid for, right?
If I may, Mr. Chair, I want to make sure we're understanding the question.
Yeah.
It sounded like, and please confirm this, that you're saying, look, if the drug is too expensive, it shouldn't be covered to begin with.
If there's no clinical advantage to the drug, and it's just a price issue. And what I'm hearing, and maybe I'm misinterpreting that, is that these coupons are used to steer physicians and patients into more expensive alternatives that may or may not be more clinically effective. Then isn't that incumbent on the PBM to do their job and say, no, we're not paying for it?
Thank you for the question. So yes, PBMs do create formularies where we pit drug manufacturers against each other.
And don't you set the copays of those drugs?
We work with plan sponsors. So let me use the state employee plan as an example. The state employee plan can go to their PBM and say, we want our employees to have a $5 copay. PBM says, sure, we can build and design that for you and administer that. The PBM does not set the copays. They work with their health plans, the state employee plan, for example, to design their benefit. Now, when it comes to a formulary, yes, PBMs will pit drug manufacturers against each other to get to that lower net price to gain access to that formulary, which then means it's market access for those for the drug manufacturers to get that into that patient pool. So manufacturers can still offer those coupons on top of that. But if there's a generic or a cheaper alternative, maybe a cheaper brand available as well, again, we just think that this is just a marketing tactic by pharma, and we think that they should just lower the prices.
Thank you. All right. Free to go.
Thank you.
Thank you. Let's see. Peter Bragdon, is that a check mark or is that a check mark that was scribbled out? Okay, you're up.
Morning, Mr. Chairman, members of the committee. Welcome to the Senate, Senators Long and Rochefort. For the record, my name is Peter Bragdon. I'm a senior policy advisor at Preti Strategies here in Concord, also a recovering senator. Here today representing Harvard Pilgrim Healthcare. As Senator Prentice knows, New Hampshire's not-for-profit health insurance provider, providing coverage for 50,000 of our friends and neighbors in the Granite State. Here today in opposition to Senate Bill 17, request that you find it inexpedient to legislate, though I will say that if there is appetite for working on this, then we're happy to participate in that as well. One of the reasons we're against this is it's kind of a one-size-fits-all approach. It says you can no longer do this, you have to do that. And it doesn't always work. So Senate Bill 17 would require health insurers like us to apply the value of, we'll call coupons. They probably started their life as coupons years ago, but I'm sure it's all pay cards and electronic now. But we apply the value of, require us to apply the value of coupons against the members' cost sharing. These programs, many times, not always, but in many cases, these coupon programs are schemes by drug companies to shift away patients to much more expensive drugs. And I'll get to that in a second. I think Senator Rochford was just asking kind of about that similar thing. The patient doesn't see the cost because the drug company absorbs the cost until such time as the deductible runs out. It's important to point out these are not contributions from friends and relatives and churches, people who just want to help out. And this is another question that Senator Rochford had. I know of no insurance company that has a problem with that happening. In fact, we have no way of knowing where that money is coming from. And the distinction is, as was pointed out, I think, by Curtis, the distinction is that the friends, the family, the church members, they don't care what the drug is that you're getting. They know you need help. They know you need financial assistance, what you're doing. They don't care what you do, just get yourself fixed. The coupon is from a specific drug company, and it's for a specific drug, and use it for that drug. So let me, I pencil out an example that I stole actually from some of the testimony last year. Let's say you have an example of somebody with a $5,000 deductible. And they have, there's two treatment options. One, there's a $1,000 drug that has been put on the formulary because we want to discourage that particular, let's say there's two drugs that are equally effective on this. One is a $1,000 drug, and so we have it on a much more restrictive formulary tier, and that has, like, let's say a $400 copay. So you want that drug, you have to pay $400. Or there's a $300 drug that only has a $200 copay. We want to incentivize people to use the least expensive of those two. And that's what would happen in a normal market. But then the manufacturer of the $1,000 drug says, hey, Mr. Or Miss patient, we have a coupon for $900. Here, have this coupon for $900. Now the copay, the patient's copay for the $1,000 drug is now only $100. It's actually half the price of what they would have to pay for the one that we want them to take. And so they use that. That has shifted the patient from the drug we would prefer that's as effective but cheaper to the more expensive one. Then they're on that, and then they get that coupon every month. Let's say it's the same thing happens every single month. Within a few months, that $5,000 deductible is now used up. The coupon stops. The patient doesn't know the difference because now the deductible is used up, so the insurance company has to pay the whole thing. So that's what happens in the cases we're concerned about. Now, there are cases where there are no alternatives available, and I think there's a legitimate issue there of trying to find a way to protect that while also protecting the insurance companies as well, and certainly happy to work on that. So let's see. Let me read a note from the, we recently formed a couple of years ago, the Prescription Drug Affordability Board, looking at the cost to public payers in New Hampshire of prescription drugs and what can be done about it. They have a section on coupons. Manufacturer discount coupons and patient assistance programs. That's the heading. Manufacturer discounts, coupons, and patient assistance programs help individuals with health insurance coverage afford high-priced medications during their deductible. However, their use may incentivize customers to utilize brand name drugs over lower cost alternatives. Manufacturers can also choose to lower the value of the assistance or terminate these programs altogether. When applied to deductibles or annual out-of-pocket limits, these payments by manufacturers shift costs to plan sponsors and undermine cost containment efforts. We have very few tools in our toolbox in terms of prescription drug prices. The biggest tool we have is the formulary. And if there are things happening that disrupt that formulary, that shifts the cost. And I said in I think it was a House hearing last year, there's no insurance fairy that shows up and says, oh, here's all these costs shifting, we'll take care of that. The costs are going to shift. There's more costs. They have to be paid somewhere, and it ends up being paid by the premiums for the members in the following years. The reason we're concerned about higher priced premiums is the higher those premiums go, the more likely it is that people don't get insurance. The more likely it is that their employer drops insurance. The more likely it is that their employer gets an insurance plan that has higher copays. So now the individual is faced with higher payments, And when it comes to deciding whether or not to get treatment for something, because that higher payment may not. So we think in the big picture, higher pressure on premiums is something to be avoided just for the overall good of the market and the individuals in the market. So again, we feel there are situations, and one thing I think that should be investigated is, I think it's have to be very careful how the wording is. It's been said that 99% of the drugs that coupons are used for don't have generics. That may be true because of the word generics. My understanding is from testimony by the insurance department last year that there's a difference between a generic and a biosimilar and a branded alternative. So my understanding is that 88% of the drugs that coupons are used for do have either a generic, a biosimilar, or alternative branded drug. So the 12% of the time, there's no other option, and there's some our consumer advocate, Don Price, testified in the House last year. His daughter has cystic fibrosis. I think he said the cost per year for treatment for that is $300,000 for the drugs, and there's no alternative. So those are things we want to be able to find solutions for, but we don't want to undermine the overall structure of the prescription drug benefits because it undermines the whole insurance market. I think one last thing I'll point out is that there was a study, I think it was in 2017. The state of Massachusetts does not allow coupons. And I can't remember if the law was changed to allow that or the study was just done at a time when New Hampshire did allow coupons to be used, Massachusetts did not. So they studied what happened with generic drugs and brand name drugs as a result of this change. 2 states next to each other, similar demographics. And the use of generic drugs in New Hampshire as compared to Massachusetts declined. Spending on branded prescription drugs, the same things, increased 60%, all at the expense of generic drugs. So there is a cost to this. I can't say exactly what it is, but I can say if there was no cost to this, this would include the state employees. This would include the town and school employees under RSA 5B. These are not included in this bill because everybody knows it's going to cost the state money and they don't want to do it. So I think we need to be consistent. It's a good policy. It should be good for everybody. Or if it's something that's going to increase costs for people, let's try and find a solution that deals with the specific area, that 12% that may not have an alternative. So I'm sorry to try and cram so much into a short period of time, but that's what it is. Happy to answer any questions, though.
Just one.
Senator Burt?
Paul mentioned something about tracking coupons.
Paul mentioned something about tracking coupons. I don't recall.
So, when you said, well, hey, I'll use the generic one until my deductible's used up, and then when it's all used up, I'd like to know when the generic is available. That seems to be a smart way to do it. But
my impression is so once people are on, let's use the example I had, right, the $1,000 drug. So the person's on the $1,000 drug, let's say for 4 or 5 months, then there's no incentive for them to switch to something else because it doesn't cost them anything at that point. The deductible's all been paid for by the drug companies, and so everything else is free to them. So there's no incentive for them to want to change.
But if the coupon was tracked, then they can automatically be. I'm just thinking out loud.
No, I appreciate that. I think you're right. Is that it would be nice if now again switching treatment midstream is probably not necessarily recommended either. I'm not a doctor nor a pharmacist. I'll let Senator Rochefort deal with the pharmacy side. So yeah, I do think a lot of it is behavior is just driven by the effect on the pocketbook, and if that effect, and that's why we have the formularies and the structure that we do with lower prices for the things we want to encourage. A price of 0 is about as low a price as you can get, and that's what they have once these coupons end.
Thank you, Senator Birdsell.
Thank you, Mr. Chair. Thank you for taking my question. So what would you say to, let's say, amending the bill to address the conditions that have no alternatives and have the high cost of conditions that require the brand name drugs?
I think we'd be very open to that conversation. Obviously, big picture wise, any tinkering or any requirements have to be carefully looked at. But I think, overall, our main concern is how this can be used to subvert the formulary. And there are some compelling human interest stories in those situations where there's no alternatives.
Thank you.
Any further questions? Seeing none. Thank you very much.
Thank you.
Next on the list is Sabrina Dunlap from Anthem.
Good morning.
Good morning.
Thank you, Chairman Rochfort and members of the committee. My name is Sabrina Dunlap, and I'm Senior Director of Government Relations for Anthem. We are opposed to SB 17 as written. I'll try not to repeat much of what was said because I think folks have covered many of our concerns about this bill. As was mentioned, we saw a very similar bill last year, SB 354, which we also found very problematic. I think there were quite a few discussions, I was part of them, about potential amendments. Unfortunately, none of those made it through the Senate. And so I think those are worth revisiting. So I want to say that, just to repeat, grounding ourselves in why we're talking about these coupon programs in the first place, and it is because of the high cost of specialty drugs, prices that are set by the drug companies. And I think Paula's question about where are the drug manufacturers is a really good question. And I agree, I don't think we heard from them at all last year, and I don't think they're here today either. But I really do think they need to be part of the discussion because they are the ones developing the drugs and setting the prices and then offering these programs to create the illusion of affordability when the drug continues to be unaffordable. I think it's worth repeating that the federal government considers copay coupon programs an illegal kickback. And I don't want that to get lost in the conversation. And also just highlighting this bill would interfere with benefit design. As Curtis said, to be clear, people can still use these programs. The question is just, should the drug company dollars that are benefiting the drug company be forced to go to a member deductible? And I do just want to point out that Anthem and other carriers have developed their own programs to help reduce members' out-of-pocket costs for high-cost specialty drugs. And this bill would interfere with our ability to administer that program. And it is very popular in the state of New Hampshire with our members. And I do just want to note, hearing from the patients is very important and very compelling. And I will just say, some of you know this, I have a child in the rare disease, chronic disease space. I'm very familiar with specialty drugs. I'm very familiar with the programs offered by drug manufacturers. And speaking for Anthem, we want our members to have access to these drugs. Some of them are life-changing. I mean, what's been done with biologics is really amazing. We want members to have access to these drugs. Ultimately, I don't think this bill helps with the affordability of these drugs. And I think if the goal of this bill is to help consumers, several of the amendments from last year ought to be seriously considered. You've heard about a couple of them. I think one that hasn't been mentioned, or maybe it has been mentioned, is just why did the copay coupon programs stop as soon as the member hits their deductible? Why not continue them for the full plan year if it's really about helping the members? And I also just note, I've spent some time looking at the drug company websites about these copay coupon programs, and there's not a lot of consumer protection for people who sign up. I'd say there's virtually none. You look at some of these websites and they say the copay assistance program is subject to change, reduction in monetary amount, or discontinuation without any notice. That is from the drug company. So I think, the discussion about consumer protection deserves more time and energy, and we would definitely be willing to talk about potential amendments on this bill. So thank you for the opportunity to testify, and I'm happy to take any questions.
Thank you. Any questions?
I have a dumb one.
Senator
Can I
Abar?
ask a dumb one?
No dumb questions.
No dumb questions.
Well, I'll challenge that. You said basically the coupons are basically illegal according to the federal government, and we're allowing it? How's this work?
So sorry to clarify, the federal government considers certain copay coupon programs to be an illegal kickback, so they're not permitted under Medicare and Medicaid.
But they are permitted under...
In the commercial space, they're permitted.
That's interesting. Thank you.
Any other questions?
Was it done?
No.
I think it was a good question. Thank you for the question.
This is complicated stuff. This was, I had to read this a dozen times. All right.
Thank
Any
you.
other questions? You're free to go. Thank you very much.
You're free to go.
Sometimes it feels like a prison up there, doesn't it?
Yeah.
The last speaker on the list, Mike Rollo. Mike Rollo. All right, sorry to keep you, but you're the last one. We saved the best for last, I guess, right? The pressure's on.
Gotta pull my fillings out. Oh, yeah. Oh, I love them. Rolos. Brought my glasses there to print it, so you're off the hook. Thank you, Mr. Chairman, members of the committee. For the record, my name is Mike Rollo. I'm the Government Relations Director for the American Cancer Society. Cancer Action Network. We are the nonpartisan, nonprofit advocacy affiliate of the American Cancer Society. We support evidence-based policy and legislative solutions designed to eliminate cancer as a major health problem. And as the nation's leading advocate for our public policies that help to defeat cancer, ACSCAN is in full support of Senate Bill 17, as we were in the bill last year. We've heard a lot this morning, and I'm going to try to stick to my prepared testimony and not go off on some of the tangents and red herrings and poison pills that have been offered. We may get to it at the end, but I'm going to try to stick to what I came to talk about first. Many cancer patients have difficulty affording the cost of the prescription drugs, regardless of whether they are insured. This is especially true for newer drugs, including cancer drugs that do not yet have generic equivalents. To help temper high prescription costs, many individuals living with cancer receive copay assistance offered through manufacturer programs and charitable patient assistance programs. Manufacturer programs and charitable patient assistance programs help many cancer patients afford their medications. In many cases, a cancer patient needs a drug that does not yet have a modestly priced generic or other alternative to drug treatment. A patient assistance program's financial support give patients access to life-saving drugs that they otherwise could not afford. And many of the programs exist for drugs without generic alternatives, which has been said several times this morning. Copay accumulators are a relatively new insurance benefit design, mostly being implemented in the employer-sponsored insurance market. These programs allow the enrollee to use copay support, or if you will, a coupon, but the amount of support does not count towards the enrollee's deductible or maximum out-of-pocket. Only the funds spent directly by the beneficiary and not on their behalf would count towards the beneficiary's deductible or MOOP. This means that patients will experience increased out-of-pocket costs and take longer to reach required deductibles. Such utilization management tactics negate the intended benefit of patient assistance programs and remove a safety net for patients who need expensive specialty medications but cannot afford them. This could lead to poorer health outcomes and potentially higher costs to the healthcare system. Moreover, copay accumulator programs often lack transparency or are often implemented without a patient's knowledge or full understanding of their quote-unquote benefit. However, the implementation of SB 17FN, with the implementation of this bill, barriers to copay assistance would be removed by requiring all payments be made by patients directly or on their behalf to be counted towards the overall out-of-pocket maximum payment or deductible. Requiring health insurance carriers to do so will protect cancer patients from surprise bills and treatment delays, as well as allowing individuals to utilize the full benefit of copay assistance programs. And to be clear, Senate Bill 17FN is not a coverage mandate and does not require insurance companies to cover any particular drug or class of drugs. Nothing in this legislation prevents insurers from using existing utilization management tools, such as step therapy and prior authorization. We're only addressing copay assistance that is being used by patients for drugs that their insurance company, the very company they're paying their premiums to every month, has already made the decision to cover, and their doctor has determined that they need. Patients still have plenty of skin in the game when it comes to making and paying for their healthcare decisions, as they're still paying their insurance premiums, and patients living with chronic illnesses don't have the luxury of foregoing certain healthcare treatments and services until they can easily afford them. For these reasons, we'd ask for your support on Senate Bill 17. Now, to speak briefly to a number of the points that have been raised this morning. The American Cancer Society Cancer Action Network is fine with including biologic and biosimilars. As has been mentioned, I think Senator Rizzo, you just asked a question about it a few moments ago. If you want to include those, that's fine. From our perspective, as I said, most of the new therapies that are being developed, life-saving therapies for cancer patients, don't have them.
So if you want to include them, that's fine. As to premium increases, I shared last year, and I apologize, I have not emailed them over to you yet, but I will as soon as I'm done speaking, if I can make my phone work the right way. The Pioneer Foundation, the AIDS Institute, and the Global Healthy Living Foundation all found, these are 3 independent studies, one from a very conservative organization, one from a more, I guess you might say, progressive organization, and one from a middle of the road, all found the same thing. And this is a quote from the Global Healthy Living Foundation. The rate of change in health insurance costs has been no different in states with versus states without laws banning accumulators and maximizers. 3 independent studies have shown that if you enact these policies, they will not have a negative impact or raise premiums. And as to what may or may not have derailed our efforts last year, you recall 3 of you sitting around on the other side of the table have already lived through this once before, and I appreciate your past support, and we hope we can continue to have your support. It passed the Senate 24-0. You recall it went to the House. There were amendments that were offered. It's interesting. I'm glad to hear that the representative from AHIP is saying that they offered the last amendment because we asked for it for forever, and we're told, well, we don't have an amendment. So I'm glad to hear that. I now know where the amendment came from. We might have been able to work on it a little closer with them. But what sunk this effort was the House amendment would have precluded the majority of charitable support. That was the problem. We don't have a problem with extending it to a full coverage year. I think that would be wonderful for patients. I say more power to you if you want to make that change. That would be wonderful for cancer patients. But if you go and you limit what types of charitable care can and cannot be accepted, you will limit a good number. And I don't know, maybe this is all coming back to Senator Birdsall and Senator Prentice. Senator Ebert, I think you lucked out on that conference committee. You were fighting in another room, I think. But that's what sunk this in the very end. And that's what Senator Bradley would not go that far because he understood, because we had lengthy conversations with him about how this would preclude the overwhelming majority of charitable contributions, charitable support that these patients were receiving. And the one last thing I want to say, and I don't want to overstep, but I have to say it. I know lots of people that have had cancer. I know lots of people right now that have cancer. I've lost my father. I've lost 3 aunts. I've lost 2 sets of grandparents to cancer. And on my wife's side of the family, it's just about the same. I'm sure every single person sitting on the other side of the table from me knows someone who has had cancer. Now, everyone's cancer journey is different. There's a number of factors that goes into whether or not someone will survive cancer. The one thing that I can say for sure, and I have no hesitation in saying this, every person that I know personally that has dealt with cancer has never gone into their doctor's office because they've gotten a coupon and asked for the most expensive or the more expensive treatment that is being offered. And to hear this time and time again this morning from the carrier suggesting that patients are going to be seeking out more expensive treatments. When you're trying to fight for your life, when you're fighting cancer, you're looking for whatever's going to save your life. You don't care how much it costs. And it's really insulting to hear that over and over and over again, that patients are just trying to find the most expensive treatment because they have a coupon. And with that, Mr. Chairman, I think I'll just stop, and I'll be happy to answer any questions.
Thank you very much. Are there any questions from the committee? All right, hearing none. Is there anyone else that would like to speak? Yes.
Thank you, Mr. Chair, for allowing me to come up a second time. Just something was said that I want to clarify. The prior speaker said that mentioned these studies that said there's no impact on cost. And one of them is by the Global Healthy Living Foundation. If you check the website of that, they have 25 corporate partners. 23 of them are drug companies. So just check the sources when you hear statements like that. Thank you.
Thank you. Anyone else? We're going to close the hearing on Senate Bill 17. I've got a motion to move into executive session and a second on Senate Bill 37. Okay. We will not be executing Senate Bill 17 today.
A motion to move, ought to pass on SB 37
So I got a motion ought to pass
with an amendment.
with an amendment. So ought to pass motion first.
Yep.
Do I have a second? All right, we're going to ought to pass in the second. All right.
And I'd like to make an amendment on page 2, line 9, changing the word hospital to facility. As a committee amendment.
Did you get that, Sophie?
Yep.
Okay.
I'll do it.
Senator Prentice is the second. So any discussion on the amendment? Hearing none. All those in favor of the amendment, say aye.
Aye.
Any opposed? So the motion now is ought to pass, and we have an amendment.
I move ought to pass as amended.
All right, any further discussion on that?
Seconded by
Seconded by Senator Prentice.
Yes.
All right. So it's ought to pass with an amendment. All those in favor say aye.
Aye.
Aye. Any opposition? No
Consent?
opposition. Consent?
Consent first.
I'll take it out.
Senator Prentice will take it out. We need a vote on consent, right?
Yep.
So all those in favor of consent, say aye.
Aye.
All right. On the consent? Yep. Senator Avard with the motion, and then Senator Bertzel with the second.
Motion to move out of exec.
Second. Quick round here.
All those in favor, say aye.
Aye.
All right, that concludes the day.
Good work, boss.
Hopefully I did it right.
You did great.
Right. And you've got all the things you need, right, Sophie? All right, very good.
Sophie, that means wisdom. Right?
Oh, thank you. I know, this is a nice room. It is hot. Everywhere's